I am Dr. Gerald Sekito Karule. I'm the Chief of Party USAID's Maternal and Child Survival Program, commonly referred to as MCSP. In 2014, after successful implementation of the Maternal and Child Health Integrated Program that was also supporting routine immunization, USAID provided funding through buying into the Global Maternal and Child Health Program to support Ministry of Health UNEP and 11 districts in strengthening the routine immunization system. MCSP in Uganda, managed by John Snow Incorporated, JSI, used a well-known and approved WHO reaching every district or community strategy, but innovatively adding quality improvement tools and approaches to form the reaching every child quality improvement approach, RECQI.
Using the Reaching Every Child Quality Improvement approach, USAID's Maternal Child Survival Program in Uganda has supported all levels of the national health system in increasing coverage and utilization of immunization services. At district level, district health officers were critical in spearheading the adoption of the RECQI approach.
We have closely worked with the implementing partners, and they have supported us to do the trainings, but also the logistics, the planning, especially for the microplan.
To implement the RECQI approach, MCSP has worked with these districts' health leaders to cascade its key processes, including catchment area population-based micromapping, microplanning to lower-level health facilities, and further to communities.
About the micromapping at this health facility, before the financial year starts, we go at the district for a meeting. Here, they tell us our parishes according to our catchment area, and they also tell us our villages. We have to involve the village health teams. We call the sub-county chiefs, the LC3, LC1, and we also involve the health workers at this facility. We hold a meeting, and we have to show them their villages according to their catchment area. They register the children in those villages, and they also take that information to the parish mobilizers.
I, as a VHT, I have the paper which we use as a register. So every child who have been born, we register on that paper. Then we pass through in the village, in the community, sensitizing them for the immunization, benefits of immunization, and how they need to be immunized. So at the end, we come to the health unit or to the outreach where the immunization is to check those people who have been mobilized, they come or not.
The EPI focal person has to compile all those children and put them in the child register according to their villages, because each outreach has its own child register. So it will help us to track all those children.
RECQI supports subnational health workers in systematically identifying routine immunization challenges or problems, their solutions, and working with the non-health stakeholders to identify and mobilize extra resources needed for routine immunization. The non-health stakeholders are the supervisors, they are the controllers of resources, so they are in better position to really support the intervention as we roll it out.
When I came to the district, I found that the motorcycle for Gavi was not given to people who are directly dealing with the immunization activities. Actually, all the motorcycles were given to health assistants and not the focal point persons. Through discussion, I have made sure that the motorcycles are given to the right person. And then the distribution of the vaccine when it reaches the headquarters here, I found that it was a challenge for this vaccine to go to the health units. I talked to the person, the focal point person. I told him the moment the vaccines have come to me, link with me so that I discuss with the DHO, and then the Gavi vehicle is used for taking this vaccine to the health centers.
We have invited them for these performance review meetings.
Last year we were invited in Kampala in a workshop, and we found ourselves being in category 4 in routine immunization. We were touched, and when we reached here, together with the chairman and the technocrats, we had to hold the meeting. We held the meeting, and we invited all the stakeholders to tell them about it so that they can go to the ground and sensitize on our behalf where we are not present. And then we invited all the health workers. We gave them tips on how to go about it, and we told them to work hard so that we can get away from category 4.
We write the publicity notes in the area, in the centers, trading centers, and we also go inform the chairman, RC1, in writing as the parish chief, and they come in good numbers. Let's use the good numbers.
We need to change our mindset. EPI is not only a prerogative of the district health officer. No, it is for all of us, because these Ugandan children are for us and they are for everybody. 2, we must work as a team, and together I'm convinced we can.
MCSP worked with Ministry of Health, Child Health Division and other partners, particularly WHO and UNICEF, to provide an above-site technical assistance to USAID's regional health integration to enhance services projects in East Central and Southwestern regions of Uganda. They identified a low-cost, high-impact child health package which was rolled out in the 2 regions.
I came on board when IMCI was born. IMCI being Integrated Management of Childhood Illnesses in 2000. But what I recollect, it had been around for at least 2 years. It was a package that came on board. It was designed to address a challenge then, that what was observed was that children in developing countries, not only in Uganda, but most of the poorly resourced countries, 80% of them, in terms of falling sick and probably dying, was related to about 5 common conditions: having pneumonia, having malaria, then we had measles, diarrhea, did I say? And malnutrition. The intention, overall goal, was to enable health workers be able to holistically examine, come up with a classification that will help identify treatment, knowing very well that most children come with multiple conditions.
Basically, Uganda actually is one of the countries which pioneered the previous approach, standard training approach for IMCI as designed by WHO for the 11 days training, and we are actually one of the few countries which managed to scale up. Within about 4 or 5 years, we had actually trained more than 8,000 health workers in all the districts in the country. But with time, it became very clear that despite the fact that we had managed to put that amount of effort, it was very difficult to scale up that model. First of all, it was a long training course, 11 days, 2 weeks, and also it was taking our health workers, depriving them from being at the health facility. And then we also learned that ultimately, when we looked at the different components in terms of what competencies were transferred, some of the components, like counseling, despite the long training, were not very different. So we considered in the scale-up effort to see whether we could actually have different models. One of the things we proposed right from the beginning is to have a staggered approach, where instead of keeping all health workers in one training at a go, that we call them, we have it face-to-face, then they go back and do some practice, and they come back to do a synthesis.
Partners, the Ministry of Health and MCSP chose to use the recently revised IMNCI approach or model in rolling out the child health package. IMNCI training took two approaches or two models. One was the distance learning approach, which was previously used by WHO, and the short interrupted course, which was recommended by Ministry of Health to roll out the child health package in the 4 demonstration districts: Luka and Kaliro in the East Central, Shema and Ntungamo in the Southwestern region.
We were called for an orientation training of trainers. What was going on well with the documents, we just okayed. So by the time we came to use them as trainers, we were already used to the document, and we knew that they would satisfy the needs of the learners at different levels.
So this distance learning in particular for this IMNCI, it is first for its kind in this schema, but to me as a leader, I'm seeing it was convenient. First of all, it didn't remove all the health workers from the facility. It was client friendly and again friendly to the participants themselves. For the facilities where I had 2 health workers, one could remain at the facility, one comes for a training. Tomorrow, the other one who came yesterday goes back, and this one comes for a training. So the client flow at the health facility, it remained constant, and again these health workers gained the package.
The mode of training was distance learning. Yeah, I've liked this training because the other time when you're going for 5 days, these things are many. You just go there, you read this and this, not even getting them well. But at least this distance learning, we had to get things in small things for a package.
We have a full day for practicals, for hands-on, where they go and like those ones who have taken too many months or years without entering the hospital, they go and practice from the hospital. They are practicing in the community, they understand.
I liked the way it was designed because it gave us time to interact with the trainers from the first face-to-face, then gave us time to read and study on our own as a group at our health facilities. We also got a lot of materials. We had the modules, we had the chat booklets, and we also had an opportunity to look at the videos and the pictures. So what we were learning, or what we got, was really a picture of what we expected.
To us, as a district, it worked. We covered many health workers in the shortest time possible.
The orientation of the health workers to the IMNCI concepts was a bit hazy for the long distance course, so because for the short interrupted course, there was a little bit of time, long exposure, so they were able to orient themselves.
Many new policies are being released all the time, and we think we should be able to send this message very quickly to the health workers down on the ground, using either electronic mechanisms or mobile phone systems instead of waiting for training. And that way, the long distance learning course may be more appropriate to serve that purpose. So ultimately, we are going to gear more to long distance learning, but for the interim, I think we're going to really push for the short interrupted model where we have them come in and then they go out and then they come back.